Okay, currently recording the office hours November 12th. We're going to look at the EKG interpretation again because there's some questions on that. So let me zip on down there. There we go. Get it back in full screen mode. There we go. It's better. Do you want me to go over the electrical system at all?
It won't hurt. Thank you.
Okay. Here is the, I'll put my pointers out again so I can torture you with my outlining. There we go. Here's the SA node. There's two pacemakers in the heart, the SA node and the AV node. When your heart decides to beat, the SA node issues an electrical signal that goes down into the left atrium and goes down into the right atrium, and those two contract. So that's the first part of your beat. Then the electrical signal continues down through the AV node, down through the bundle of His, which does not contract anything. That's just like a pipeline. That's a conduit. And then the electricity flows off into the left bundle branch to contract the left ventricle, and it branches off into the right bundle branch to contract the right ventricle. And hopefully these both beat at the same time. So the atriums contract at the same time, then the signal goes down and the ventricles contract at the same time, so that you get a normal lub-dub type heartbeat. Now, I know we've talked about S3s and S4s before. Well, that's when one of these is contracting before the other. You'll get a gallop, or you'll hear a lub-lub-dub, lub-lub-dub, or a lub-dub-dub, lub-dub-dub. That's because of something wrong with the heart, muscle stretched out, damage from a heart attack or whatever. These two don't contract at the same time, and that's what causes that gallop in your heart. That being said, let's look at the EKG strip. You will be beat to death with EKG strips if you work in the hospital. Now, you're not going to deal with those probably at the SNFs or the skilled nursing facilities because they rarely have anybody on an EKG monitor. But as a nurse, you're going to be expected to be able to interpret an EKG strip and tell somebody if that's normal sinus rhythm or too fast or too slow or whatever. If you really want to get into the more advanced EKG interpretation, then you could go to ACLS or go into cardiac ICU and stuff, and there you'll get beat to death with all kind of cardiac interpretation. I think I have a, but yeah, here's a better one right here. But anyway, on the EKG machine, if we go back here, you can see that I want to get you out of. Let me go back another. Go back one more. There we go. That's what I want. Here's the EKG machine. We see those in every hospital. I think they have them in the skilled nursing facilities too. Normally a technician, or I don't even know if they train the CNAs to do this or not, but normally the technicians will hook the patient up to an EKG or an ECG and get the ECG strip. But as a nurse, you should know how to do it also. And I think we're going to try to include this in our skills set next quarter during clinical 4. We will show you how to hook somebody up to an ECG machine. If we have a male student, we usually use them because they don't mind having a bare chest in class. Of course, we don't expect that, of course, of the female students. But moving on. So when we hook them up to the machine and we push the print button, this is what we get right here. This little, it's called a 12 lead. If we move forward, if you just have somebody hooked up to a monitor that's at the bedside and we just have 3 leads going to them, 1, 2, 3, sometimes it's 3, sometimes it's 5. The old ECG machines by the bedside had 3 leads. The more modern ones have 5 leads, so they can give you more different perspectives of the heart. In our simulation lab, I'm not sure if we have 3 or 5, but anyway, you'll see that when we get there. But this is just a simple ECG strip. If you hook them up to an ECG machine, you will get this readout right here. And there are 12 different leads. 3, 6, as you can see, we have, yeah, you see there are 12 different interpretations right there. So that's why they call it a 12 lead. But the important thing about that is that you know what a normal ECG wave looks like. You remember when the electricity went from the SA node down to the AV node, it made the atriums contract. So this little section of the ECG right here is called the P wave, or the PR interval. This is just showing you that the atrium is contracting. Once the electricity goes through the atrium and hits the AV node, it passes through into the ventricle, and then your ventricle is going to contract. And that is what causes the QRS. The QRS wave shows your ventricles contracting, both of them, hopefully at the same time. After the ventricles have contracted, they need a break. So they relax, and the potassium goes back into the cells, the calcium comes out of the cells, and the muscle does what we call repolarization. Repolarization is just another term for the muscle preparing to depolarize again. Depolarize means contract. So the last part of the wave here is the ST interval, or the ST wave. Sometimes you'll get a little U wave here too, but that's more advanced and we're not going to talk about it. One important thing to know though is usually when somebody is having a heart attack, myocardial infarction, this ST wave will elevate and it'll look something like this, maybe almost as tall as the R wave. But when we go back and look at this here, and the doctor looks at this and goes, oh my God, we've got ST elevation in 1, 5, and 6. It means that this ST wave is elevated right here in leads 1, 5, and 6. And what those different leads tell us is what part of the heart they're having trouble in. So I think 1, 5, and 6, or I think 1, 4, and 5, I can't remember. It's been a long time since I've done this, but if you have ST elevation in V1, V4, and V5, it means it's an inferior wall, or the heart attack is happening at the very bottom of the heart. So, the doctors can interpret that. And if you want to go on and do more cardiac, you will be interpreting that also. That's way beyond what we're going to cover this year. Mostly, I just want you to be familiar with the PR interval, the QRS interval, and the ST interval. Those are the 3 parts of your heart wave. Any questions on that at all?
No.
We might, every once in a while, we have someone in the class who was a telemonitor. They were, you don't have to be a nurse to do this stuff. They can just give you a class, and you can be a nursing assistant or a technician or whatever. And you sit at the monitors all day, and you'll have 5 or 6 or 10 patients out there hooked up to a monitor. And you're sitting there and you're watching those monitors to make sure nothing goes wrong with their heart. And usually about once an hour or so, the technician will print out a strip on a patient, and they'll have a strip like this. And what the technician does is goes in and has a little pair of calipers, and they measure how long the PR interval is and how high it goes. And they'll write down here, they'll write it down, they'll say, okay, this is 5 millimeter or whatever. Then they measure the length of the QRS and how high it goes, and they write that information down here too. And then they look at the ST wave and they write that information down here. And that's part of their job as a technician, is looking at that Because then the doctor can come by and look at it and see, oh, is this ST wave going up? Or is their QRS getting wider? You know, they can look at that information and make sure the person's heart is doing what it's supposed to do. Mostly in the practical nursing course, we just want you to be familiar with the basic construction of that heart wave. And as we go through, I'll show you what they look like on the strips. Here are some normal measurements. I am not expecting you to know these at all. If you want to learn, get ECG interpretation, you can do that at your hospital. But 60 to 100 beats per minute, you might want to remember that. So does that answer your question? Do you want me to go any further with this?
If you can please go over like more about sinus bradycardia so that we can be able to differentiate more normal.
Sinus bradycardia just means the heart's too slow. Now you remember the normal heart rate is 60 to 100. So if it's below 60, it's the heart's too slow. A variety of things can cause this to dig toxicity. Healthy athletes might have a lower heart rate, but for them, it's not abnormal, it's normal. But other heart disease and stuff like that can cause a low heart rate, and that's not normal, that's bad. But let me see if we have, okay, we don't have any. I think I've got some strips that show that, but I'll bring those up later. Sinus tachycardia is when the heart's too fast. Now, the easy way to remember this is bradycardia. Brady means slow. Tachy means fast. I wish there was an easy acronym or something to remember for that. There probably is one out there somewhere, but I don't know what it is. I've just been around it so long that I just know off the top of my head that Brady is slow, tachy is fast. Now, one way you can maybe remember this is tachy, like tachometer in a car, shows how fast your engine is revving. So that's maybe one way to remember how the tachycardia means fast, bradycardia means slow. Because we use tachy and brady in other things too, like bradykypnic means you're breathing too slow. So you see brady and you'll see tachy in other uses as well. But that's basically all that is the heart too fast or the heart's too slow.
Oh, I meant as in to see that one in the ECG interpretation, that like that's hard to differentiate.
Yeah, let me, I do have some strips. Let me see if I can bring those up. I'll get out of this and rhythm strips. Here we go. Now I showed you let me show you the normal sinus rhythm again. And normally you'll get used to reading strips. When you do, you realize 1, 2, 3, 4. Okay, there's 4 boxes between the QRS waves. Okay, and you'll learn how to interpret how fast that means the heart is going. I know if there's like 2 boxes between the QRSs, you're tacking along at about 200 beats per minute. This would be more like 150 beats per minute. This is more like 80 beats per minute. So, you know, the faster your heart's going, the closer these waves are going to be to each other. This is, okay, don't have a pen on there. But anyway, so if the waves are really close, and I'll show you a tachycardia, but just kind of keep this image in mind this is normal sinus rhythm. This is what your heart and my heart looks like. I actually think that ST wave is a little high, but they're saying that this is normal sinus rhythm, so we'll go with it. That being said, let me get out of that one. And then I will show you sinus Brady. Wish it was an easier way to do this. This is a lot of steps. I should probably add these into the PowerPoint slide. I'll do that in the future. But as you can see, here is the sinus bradycardia. And see how that differs from the, sinus, from normal sinus rhythm? In normal sinus rhythm, you had another wave right here. You know, boom, boom, boom. The heart slows down, the waves are further apart. So you've got 1, 2, 3, 4, 5, 6 boxes in between these two waves. So you can look at that, and after you've done this for a while, you'll just look at that and go, oh, that's sinus Brady. Because you can see how slow the waves are, how slowly the ventricle is contracting there. So you see that? Does that make sense?
Yes, it does.
Yeah, okay.
Thank you.
Now let's take a look at sinus tachycardia, because I got one of those too. Where are you? Here, that's ventricular tachycardia.
So the tachycardia will be more closer, right?
Yes, I'm going to bring this up for you right here, and this will show you what the tachycardia looks like. Now, one thing to remember, and like I said, I'm not going to expect you to know all this. I just kind of want to get you familiar with it. But, you know, on average, there are about 4 boxes in between your waves. And there's a little chart out there. If you ever do EKG, there's a little chart that says, okay, if there's 1 box between the 2 QRS waves, your heart's going this fast. 2 boxes is this fast, 3 boxes is this fast. But usually about 4 boxes in between the QRS waves is average for a person. If you look at this one, you'll see there are 2. There's 2 boxes in between them. So this heart's going real fast. And just look how close the waves are to each other. You know, it's like boom, 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 boom. This guy's really tacking along pretty quick. It's been a while since I've interpreted these, so I can't remember the numbers for the boxes, so I can't tell you what his heart rate is. I've just been out of it for so long. I probably should go back and familiarize myself a little more with it. But I mean, there was a time there you can just look at that and go, boom, boom. Okay, he's about 150. He's tacking along at about 150. So that's the difference. You see the difference between those two.
Yeah.
What I should do is I'll probably take these strips and put them into the PowerPoint so that you can see the difference between the bradycardia and the tachycardia. I don't know why I did it before. I should have done that. Any more question on that? Do you want to see the PVCs or the PACs? I did put those in the PowerPoint slide.
Yes, they were. Thank you so much.
Okay. Any more questions on that, on the ECG strips?
Yeah, like for example, how do we differentiate like between if we see the strip of like snooze tachycardia and another one is like
Bradycardia?
Like ventricular tachycardia, because both is tachycardia. So how we gonna differ the snooze tachycardia and the other ventricular tachycardia?
Okay, if I understand, you're asking between regular tachycardia and ventricular tachycardia?
No, between the ventricular tachycardia and like a snooze tachycardia. If I see both strip, like how easily I know there is tachycardia because it's closest the ventricular line, but like how I can differentiate that's snooze or like ventricular tachycardia.
The, let me bring the share screen up again. With normal. I am screen sharing. Okay, good. Let me make sure that I was doing that what I was supposed to do. Okay, you saw with regular sinus tachycardia, these waves are really close to each other, right?
Yes.
Yeah, you got that. So that
Mhm.
ventricular tachycardia is very unique. And ventricular tachycardia is, oh gosh, I thought I had a picture of that in here, but it doesn't look like I do. Okay, let me stop and I'll go out and I'll get one. Okay, so there are a couple things in here. Okay, let's see what we got here. Here we are. I need to be sure to get these strips put up in the PowerPoint because you're right. You guys need to be able to see this.
Thank you.
I'll tell you, I'll go ahead and I'll post the strips in an announcement. That way you guys can see them. Yeah, I put the ventricular fibrillation in, but I didn't put the ventricular tachycardia. With ventricular tachycardia, the ventricle just takes over completely. And this heart is just, all you have is a QRS wave. This is the QRS right here. This is your ventricle contracting. And it is a big wave. It's a very ugly wave. There's not even any room in there for a P wave or an ST or anything. Basically, your ventricle is just banging away. And with this, you cannot get blood flow back in the heart. So basically, your heart is just pumping empty and not giving your heart time to refill. So if somebody is in ventricular tachycardia, that is a life-threatening rhythm. They're going to be passing out. They're going to be laying on the floor. Unlike sinus tachycardia, where everything looks normal, the waves are just closer together. Does that make sense?
Yes.
But when you look at ventricular tachycardia, it is ugly. It is a big, ugly wave. So we also call these tombstones because this little wave right here, it looks like a tombstone.
Oh.
So sometimes you'll hear doctors refer to it as tombstones. This is bad. If you see this rhythm, the person is lying on the floor. You may not even be able to feel a pulse. You're going to do CPR. You're going to do the whole CPR thing. And the best way to get him back to a normal rhythm is to defibrillate him.
Okay, but the snooze tachycardia is we have P wave and
Yeah.
QRS and T, maybe that way.
Yes.
Okay.
Let me and I'll bring I'll bring the sinus tachycardia. No, that's ventricular tachycardia. Sorry. Where's the sinus tachycardia? Oh, here it is. Do you guys see that?
Yes.
Okay. Here's a sinus tach. So you got your P wave right here. You have your ST wave right here, and you have your QRS. And your QRS is a normal width. That's normally how wide the QRS is.
Bryce, it's still on the folder. We can see the
Yeah,
whole.
in the folder.
Oh, okay. Let me stop the share. And go to share. Yeah, here, share here. Here is your normal. This is sinus
Yes.
tachycardia. See, here's your P wave, here's your PR interval right here. Here's your ST, and here's your QRS. The QRS is a normal width. So it looks just like normal sinus rhythm, only the beats are closer together. Now this
Yeah,
is
the
not-
beat is only 2 bucks. That's
yeah, this is the person's gonna not feel well, but they're gonna be okay. And you can usually give them adenosine or something like that and slow this wave down. But you can see the difference between that and the ventricular tachycardia. The ventricular tachycardia, they were just ugly waves like this. And that it's just ugly. And then when you get into ventricular fibrillation, it's all over the place. It's just like that. It's just ugly. That's just the best way to describe those waves. Ventricular
Okay.
fibrillation is just, you're actually having a heart attack and they need to defibrillate you. Do I have? Okay, here's another VFib. I'm going to bring this up and show this to you. Here is another example of ventricular fibrillation. And ventricular tachycardia, remember you had the waves were, I don't have a, oh, there we go. You know, you had a somewhat normal rhythm, but you're really not going to feel a pulse on that. With ventricular fibrillation, it's all over the place. It's just an ugly rhythm. It's like somebody took a pen and just started scribbling on a sheet of paper. You see that on an EKG. It's either one of two things. One, your leads are loose and you need to go in and check the person's chest and make sure that the leads are connected properly. Because if you walk in the room and the person is looking at you saying, "Hi, how you doing?" They're not in ventricular fibrillation. But if you walk in the room and you see this rhythm here and they are passed out, dead to the world, that would be true ventricular fibrillation. And that's when you need to defibrillate them.
Okay.
Any questions on that? I'm glad you pointed that out. I need to go back and put some more rhythm strips into the PowerPoint so you guys can see these. And
Thank you.
with the instruction too, because I can point out the differences between them.
I have a question about the cardiovascular, the ATI one. Are we supposed to like memorize all the medication, the calcium broker things? Okay. Okay.
What you want to memorize is what I point out in the PowerPoints. Because when you do the cardiovascular medications in ATI, I just want you to kind of be familiarized with them.
Okay.
Because that's a lot of medication.
It is.
And when we get to, I think it's this week, the PowerPoint that I just did, we get into hypertension. It's unfortunate, but there are like 8 different classes of drugs that we use for high blood pressure. I only want to familiarize you with about 4 of those because you can really easily get overwhelmed with all the high blood pressure medications. So, but there's some basic ones you really need to be familiar with, especially diuretics, beta blockers, ACE inhibitors. Now, those are the most common blood pressure medicines that you'll see every day in the skilled nursing center or in the hospital. So,
Okay.
but yeah, I still want you to be, familiarized with them. I want you to see all 8 of them. I want you to look at them. And the drug families are something that you should probably be familiar with. What does an ACE inhibitor do? What does an ARB do? What does a diuretic do? But as far as memorizing specific drugs, what we're hoping to do, Chuchi is going to be taking over pharmacology because Andy is leaving.
Oh, Andy's leaving?
What's that?
You say Andy's leaving? Oh man.
We keep losing nurses. I don't understand it.
Mm.
But we got Chuchi on board, another nurse named Laura Cooper. But Chuchi has taken over for Andy. And we both agree that what we want to do with pharmacology is just make you familiar with the drug classes. And then when you get out into med-surg, in med-surg, we'll tell you what specific drugs under that drug class that apply to that specific pathophysiology. For example, in pharmacology, we want you to learn what is a diuretic? What does a diuretic do? And then when you get into the cardiovascular, it's unfortunate that you get cardiovascular before you get pharmacology. So that's just, it's unfortunate. But when you get into cardiology, you'll learn that a diuretic is given to a person with heart failure to help them get fluid out of their body and get fluid out of their lungs. And then we'll talk about a specific diuretic like Lasix, furosemide. So you learn the drug class first, and then as you go on in the program, we'll start covering some more specific drugs. So hopefully that'll make it easier to understand.
Yeah, thank you so much, Bryce.
Thank you.
Okay, any more
You do-
questions at all?
You teach us pharmacology next quarter?
What's that?
You teach us the pharmacology next quarter and
No.
research?
Chuchi is teaching.
Oh, okay.
Next quarter, I'll be teaching Med-Surg 1. In Med-Surg 1, we're going to talk about hematology, you know, how you make blood and diseases of the blood. And we're going to talk about immunology, the white blood cells and dysfunctions of the white blood cells. Since we're going to hit immunology, traditionally, we've always hit AIDS real hard because that was mandated by the state. But what I would like to do in immunology is hit COVID real hard, because I really think that COVID is more of a problem right now than AIDS is.
Yeah.
I think everybody would agree with that. So hopefully when we get to immunology, I'm going to hammer you guys with COVID, and so that we get to know that pretty well, because you guys are going to be dealing with that.
Yeah.
Okay.
Okay.
Yep. Thank you so much for your time.
Thank you.
You're welcome. I'm going to stop the recording and I'll